Thank you, Marcia. Okay, I'm pleased to be here to talk to you guys about cardiovascular disease, and I'm really going to focus today on primary prevention. So when we talk about primary prevention, it's really trying to prevent the first event, the first stroke, the first heart attack, as opposed to secondary prevention, where we're really trying to prevent recurrent events, and we have slight differences when we talk about those two. So I will go through a few types of heart disease, and I'm going to really focus on the type of heart disease that has a preventable component. And in primary prevention, one of the most important things that we do is make a proper risk assessment. That aspect is very important. So I'll talk about traditional risk factors, which many of you may be familiar with, and then non-traditional risk factors, which tend to disproportionately affect women and are very important in terms of making a proper assessment. I'll talk about the use of risk calculators, and then once we've made a risk assessment, how we decide which preventive strategies to endorse. So the American Heart Association has the Simple 7, which is 7 different lifestyle modification areas that we can be working on, and then I'll talk about statins and aspirin. So cardiovascular disease is the leading cause of death for women and men in the United States. 1 in 4 deaths are due specifically to coronary heart disease. And even though heart disease is felt to be a disease of older people, it actually affects younger people. So it's the second leading cause of death in women between the ages of 45 to 64, and it's the third leading cause of death in younger women, 25 to 44. So let's talk about the forms of heart disease that are preventable. So we're going to talk about ischemic heart disease, and so there are 2 major types, obstructive coronary artery disease and non-obstructive coronary artery disease, and we'll go through 3 different types. So the first is obstructive coronary artery disease. So this is your traditional male pattern atherosclerotic heart disease. So you see on the left, that's a nice healthy artery. The lumen is nice and wide. The blood's flowing really well. And then you look on the right and you see a lipid plaque. And you can actually very clearly see that the lumen has actually shrunk by about 50%. And so that's what we call obstructive coronary artery disease. Interestingly, women, on angiography, they actually have a lower burden of obstructive coronary artery disease. So what women tend to have is something called non-obstructive coronary artery disease. So this is an important form of coronary artery disease because 1 in 10 people who present with a heart attack actually have this form. And it makes it difficult because the underlying cause of the heart attack is not clear. And like I said, it tends to happen in women. The good news is that the 12-month or 1-year all-cause mortality for women who present with this is actually better than if you had obstructive heart disease. So I'm going to talk about 3 different types of non-obstructive coronary artery disease. The first one we're going to talk about is coronary microvascular dysfunction. So the microcirculation is actually a really large bed of very small vessels. So they include vessels that are 0.5 millimeter diameter, so they're very, very small, and they're very extensive. This circulation is very extensive. So you can see on the right, this is the microcirculation, so it is responsible for a large portion of the myocardial perfusion. So these small vessels actually come off the larger vessels, and they regulate all the blood that's going through the heart muscle. So they can become diseased, and they can become obstructed, and when they do, they actually can decrease in size and then decrease in number. And the lining of all of these cells include an endothelium. So the endothelium is the inside lining for all of these small vessels. So that brings us to the next type of coronary artery disease. This is endothelial dysfunction. So this is a dysfunction of the inside lining of these arteries. And so the endothelial cell is very important because it actually secretes molecules that helps the artery know when to constrict and when to dilate. So it secretes something called nitric oxide, and when it does that, nitric oxide helps the vascular smooth muscle, which is on the just outside the endothelial layer, to dilate, to relax, and actually the artery dilates, then you can imagine blood is flowing. And so when we have dysfunction of this particular cell layer, it actually can then bring on atherosclerosis, because anytime this cell layer is dysfunctional, it promotes laying down of plaque. The good news is it actually can be partially reversed, if not completely reversed, by modifying risk factors. And then the third type of non-obstructive coronary artery disease we'll talk about is something called a myocardial bridge. And the reason I mention this is even though this is an anatomic difference in people, it does bring people to the emergency room and to the hospital with angina. And so what it is basically your heart arteries are formed on the outside of your heart normally. But for some people, probably about 30% of people are born with mostly if it's going to happen, it's the left anterior descending artery, which is the large artery that you see going down the center of the heart. So if you look at the cross sections here on the right, you can actually see that the first picture you see is the left anterior descending on the top of the heart. Sometimes a bridge can form where it actually tunnels underneath the muscle, and the severity of this tunneling can be pretty severe, where you can actually see the muscle is literally grown on top of it, or it can be more superficial, where you see just part of the fat on top of it. And these myocardial bridges can be long, they can be short, they can be deep or superficial. And the reason I bring it up is because the endothelial layer inside that bridge can become dysfunctional. So when we talk about primary prevention, the really important thing is really to do a very good risk assessment. And so when we talk about risk assessment, we like to look at risk factors. So I'm going to go over the traditional risk factors that you guys have mostly heard about, and we break them up into these fixed, modifiable, and then risk equivalents. So fixed risk factors are things that you can't do anything about, but they do matter. So we consider your age to be a risk factor once you're a female and you're above the age of 55, and if you're a male, once you're above the age of 45. And then your family history matters, and we'll talk a little bit more about that. And the modifiable risk factors are things that you have control over, you can change. This is your weight, your diet, how active you are, whether or not you have high blood pressure, how well controlled it is, your lipids, and whether or not you smoke. And then risk equivalents are considered disorders or diseases that put you at such high risk for having heart disease that we will treat you very aggressively. So things like diabetes. If you've had a stroke already, then you are at very high risk of having a heart attack as well. Peripheral artery disease is also a risk equivalent. So then I want to talk about the risk calculator. So we use a lot of traditional risk factors inside something called a risk calculator. So this particular one is commonly used here in the US. It's called ASCVD, and it stands for Atherosclerotic Cardiovascular Disease Risk Calculator. And this was put out in 2013 by the American College of Cardiology and American Heart Association when they updated their cholesterol guidelines. So they created this calculator. And what's different about this calculator versus those we used to use is this actually does factor in ethnicity and also gives us a risk for stroke. We used to just have risk calculators mostly for heart attack. So this tells me, when I put people's risk factors in, it'll tell me in the next 10 years, what's your risk of having a heart attack or a stroke or dying from either of those? And so the thing about the calculators to remember is they do tend to underestimate a person's risk if you're young. And the main reason it does that is because age is one of the strongest determinants for heart disease and cardiovascular disease. So if you're young, it'll underestimate your 10-year risk. So it's really important to look at something called a lifetime risk or 30-year risk. So this is just an example. These two bars here, the blue bars, just pay attention to the blue bars. This is an example of the 10-year risk for a 55-year-old woman who's white, who has hypertension, and that's her 30-year risk or lifetime risk on the right. And what you see is that even though she has hypertension, she's 55, her risk of having a heart attack or a stroke in the next 5 years is probably about, or the next 10 years is about not quite 5%. But if we actually look at her lifetime risk, it's nearly 40%. So if we only paid attention to her 10-year risk, we're really underestimating this woman's lifetime risk. And so it's really important to then think about what are some other things that contribute to her lifetime risk. And so we're going to talk about non-traditional risk factors. But before we do that, I do want to point out what family history means. So family history is something that the most important thing about it is if you have a relative who's only 1 degree separated from you who has early heart disease. So this mother, father, sister, or brother. And early heart disease is considered in a man who's less than 55 or in a woman who's less than 65. And we do care also about secondary relatives and third-degree relatives, but what's most important to the person is we're really trying to understand the hereditary component of the family history. So the first-degree relative matters the most. We also care about family history of elevated cholesterol to help understand what our patient's cholesterol numbers mean, and also a family history of sudden death, especially if it's through several generations. So let's talk about non-traditional risk factors. So non-traditional risk factors are risk factors that have gotten a much less press, I suppose. It's definitely not much in the popular media, I would say. These are risk factors that are definitely emerging, and we have a lot more research that shows us that they really do matter and they affect women's heart disease. And like I was saying, these tend to disproportionately affect women. So the first three, preterm deliveries, that's delivery before 37 weeks, hypertensive disorders of pregnancy, and gestational diabetes are three different risk factors that, again, happen in pregnancy, so happen to women potentially. Autoimmune disorders are disorders of, they're inflammatory disorders where your body's actually attacking its own tissues. And then breast cancer treatment and depression. Those are both things that tend to affect women more often. So we'll talk about the pregnancy complications first. Gestational diabetes, hypertensive disorders of pregnancy, preterm birth, and growth-restricted baby is where baby is born smaller than it should be. And then large for gestational age is baby who's born larger than it should be. And large for gestational age is typically something that we see in babies who are born to mothers with gestational diabetes. And they've been given a lot more glucose, and so they grow really large before they're delivered. And so the reason why these complications in pregnancy matter is they have been associated with increasing a woman's risk for having future cardiovascular disease. So let's talk about hypertensive disorders and what they are. So this is a really common problem. It happens in about 5 to 10% of all pregnancies worldwide. And it's defined as a blood pressure of greater than 140/90 on 2 separate occasions. And we have several different types of hypertension disorders in pregnancy. Gestational hypertension is blood pressure that's high that occurs at greater than 20 weeks gestation. And in a woman who previously had normal blood pressure, chronic hypertension is high blood pressure in a woman who previously had high blood pressure. Preeclampsia and eclampsia are severe forms of high blood pressure in pregnancy that are also associated with some other organ problems, primarily proteinuria or protein in the urine. And then another severe form called HELP, which is where we see anemia, where they're breaking up their blood cells, as well as low platelets. So in terms of its risk for cardiovascular disease, women who have hypertensive disorders of pregnancy have a 2-fold increased risk for having heart disease, stroke, and blood clots. They have a 3-fold increased risk for having diabetes, a 4-fold risk for having high blood pressure in the future, and these disorders can actually manifest quite early, even after the pregnancy, so even 2.5 years after her pregnancy. So just talking a little bit more about gestational diabetes, the reason this one's really important is because it is also very common, and a woman who has gestational diabetes has a 7-fold increased risk of having diabetes in the future. And as we discussed before, diabetes is considered such a high risk for having future cardiovascular disease. And so this is just a picture of large baby and normal baby. So you can really see it can create quite a lot of complications even during the delivery to have to deliver such a large baby. And so this is a good time to kind of talk about how inflammation sets people up for cardiovascular disease and its role that it plays. So, because we're going to move on and talk about some autoimmune disorders. So chronic inflammation does increase a person's risk for having future cardiovascular disease. And so what you can see is in yellow, there's several different disorders that cause chronic inflammation. So things like obesity, smoking, any other kind of chronic inflammatory disease like autoimmune disorders. They create inflammation, and then inflammation sets the endothelium up to be dysfunctional. That causes the endothelium to be more likely to lay down plaque or atherosclerosis, or atherogenesis, and then that leads to coronary artery disease and stroke. So I wanted to highlight specifically 2 specific autoimmune disorders. These are fairly common. The first is lupus. So lupus is an autoimmune disorder that actually affects many different tissues in a woman's body, and it does disproportionately affect women. There's a ratio of 9-to-1 women to men, and it's thought of as that butterfly rash across your face. And women who have lupus actually have a 10-fold increased risk for having a non-fatal MI. So that's a really large risk, and an 8-fold risk of having stroke compared to the general population. There is an ethnic difference as well. So Black women tend to have more adverse outcomes than other groups, and their severity of disease tends to be greater. And these scoring systems that we went through, they do tend to underestimate the cardiovascular risk in this population. Rheumatoid arthritis, another common one. So disproportionately affects women. It's 2.5 to 1 ratio. And this is an autoimmune disorder that typically affects the tissues within the joints and causes swelling and then ultimately disfiguration. With rheumatoid arthritis, there's a 2 to 3-fold higher risk for having heart attacks. And this is very comparable to having diabetes. So you can see that even though rheumatoid arthritis is not considered a traditional risk factor, it confers a lot of risk, a lot of increased risk. There's a 50% higher risk for stroke. And the good news is that decreasing the inflammation does seem to help decrease the cardiovascular risk. There has been created a multiplier of 1.5 that we use with these risk calculators to help us more accurately assess this person's risk if they have rheumatoid arthritis. And then moving on to breast cancer treatment. So the modalities that they use to treat breast cancer, radiotherapy and chemotherapy, they can be toxic also to the heart. So we'll talk about radiation first. Radiation, especially if it's on the left side, the left breast where the heart is, does tend to increase the risk for cardiovascular disease. And radiotherapy in general, if the woman already has cardiovascular risk factors, she's at even greater risk for cardiovascular disease if she gets radiotherapy. Some of the cardiovascular side effects can definitely they can occur just a few years after treatment and be seen as far out as 20 years past treatment. So usually we recommend that any woman who's received radiation to the left side of her chest, in particular, that she actually have some increased screening or risk assessment. Chemotherapy, there's certain types of chemotherapy that also are toxic to the heart, and these women also need additional surveillance throughout for the long term. And then depression. So depression is definitely more increasingly recognized as a risk factor for cardiovascular disease, and it does tend to occur more commonly in women. And there are poor outcomes associated if people do have depression and cardiovascular disease. There are poor outcomes for them. And the mechanism by how this happens is, as you can imagine, depression can certainly lead to change in behavior, but also depression certainly and other types of anxiety and stress lead to different biologic changes that can promote endothelial dysfunction. So then when we talk about primary prevention, once we've made a risk assessment, what we tend to do is we look at the traditional risk factors, we look at the non-traditional risk factors, and sometimes the non-traditional risk factors, we use them for is to bump up a person's risk. So if their calculator, their risk is not very high, but they have several non-traditional risk factors, it might prompt us to do additional testing to more, better assess their individual risk. And once we've done that, we sort of come up with preventive strategies. And the most common one are lifestyle modifications. And this is really foundational to cardiovascular disease prevention. So the American Heart Association has something called the Simple 7, and it's not called Simple 7 because they're simple. I think so these are really hard to do because they're lifestyle modifications, but they're definitely really important and foundational to everything. So one of them is getting active. If you're inactive, eating better, losing weight, or at least having a normal BMI if possible, not smoking if you do smoke. And the last 3 are really controlling these different numbers: your cholesterol, your blood pressure, and your sugar. And with blood pressure, I sometimes find that people don't recognize how important blood pressure control is. So especially if you have hypertension, blood pressure control is very important in terms of cardiovascular disease prevention. And then reducing blood sugar, even if you don't have diabetes, blood sugar management is extremely important because even before diabetes, there's pre-diabetes. And before that, there's insulin resistance. And so all of these things are important because they play into the inflammatory response. And just to kind of show you a study of how important it is to modify these different risk factors, I'm going to talk about the ERIC study. So this stands for the Atherosclerosis Risk Community Study. So this was a prospective cohort study. They recruited from 4 different U.S. communities, 12,700 participants, free of cardiovascular disease at the start of the study. So they started enrollment in the late 80s, and they followed these people for about 20 years. And what they did was they took this population. They looked at those 7 health metrics from the Simple 7, so smoking, BMI, physical activity, diet, total cholesterol, blood pressure, and fasting blood glucose. And they broke people up into categories: ideal, intermediate, or poor. And so you would be put into an ideal category if all 7 of your health metrics were ideal. So for example, if you had a normal BMI, you didn't smoke, and you ate a healthy diet, those would be that would be the ideal. If you had all 7, you'd be considered ideal health category. Intermediate, you would meet that, you would be fit into that criteria if one of your health metrics was in the intermediate category, and you would be in the poor health category if you had one of those health metrics in the poor category. So for example, if you smoked, you'd automatically be in the poor health category. So it's pretty strict criteria. So it might not be surprising to you, but this is how they sort of broke up. So as you can see, only 0.1% of this population had all 7 health metrics in the ideal category, and 83% had them in the poor category. And so even though this is perhaps not, this may be very representative of the general population, because the cohort was actually quite representative of the U.S. population. So you can see that we actually all have room to improve. And so one of the things that they've done is they followed these people for 20 years, and they looked at the cumulative incidence of cardiovascular disease. So these different lines actually represent how many health metrics you have in the ideal category. So you can see that at the very top, if you had 0 in the health category, you had over 20 years, you had like a 45% incidence for cardiovascular disease. But for each additional health metric that was ideal, you could see that you decrease your risk for cardiovascular disease. So even if you had 4, not even 7, but if you had 4 health metrics in the ideal category, the difference between 45 and like 9%. So it's a really big difference. And so this is just to sort of hit home that idea of how important health behavior is. And so I want to specifically talk about exercise. So exercise again and again has really consistently shown that it's helpful in terms of reducing cardiovascular risk by about 30 to 40%. And women appear to maybe benefit even more than men. So the guidelines, the federal guidelines in 2008, in 2008, the federal government came out with physical activity guidelines, and it was based on a lot of prospective data. And when they looked at the relative risk reduction for women, it was about 40%, and for men, about 30%. And so this inverse relationship between physical activity and coronary heart disease and cardiovascular risk has been extremely consistent. And exercise tends to help your cardiovascular risk factors in many different ways. And just as an example, if you exercise, your blood pressure goes down by 5 to 8 millimeters of mercury, regardless of whether or not you've lost weight. It just automatically brings your blood pressure down. So if you think about it, it's a great treatment for hypertension. And so it's one of those things where we can't underestimate all the behavioral modification that we can make to help us prevent having to use medicine or that much more medicine. And so these are the guidelines, just so everybody knows what they are. So it's 150 minutes per week of moderate intensity activity, or 75 minutes per week of high intensity, or an equal mix of both. And I don't want to forget that muscle building activities at least 2 times per week is part of the guidelines. And there is good research to suggest that muscle building helps in terms of metabolism. So for people who have diabetes, for example, if they do aerobic activity and they muscle build, they build their lean muscle, it actually helps bring their A1C down. And then, of course, some is good, but more is better. And so the minimum is what we've just shown you here, but if you want additional benefit, sort of increasing that exercise above this baseline is great if you're like a high achiever. So what is moderate and vigorous exercise? So moderate is like where you can, and it's different for every person, because depending on your physical fitness, some activities may be quite hard for you and others quite easy. So it just depends on the person. But moderate's defined as you're able to talk, but you can't sing your favorite song at the same time. Vigorous would be you can't say more than a few words at a time without pausing during that activity. So what is it not? Okay, so usually for most people, their activities of daily living, shopping, walking their dog that sniffs a lot, that doesn't really count unless you're running when you're shopping. Okay, but you kind of get the picture, is like it really takes a lot of effort to work it in, and we can't necessarily rely on our activities of daily living to count for our exercise. And then what should you eat? I feel like in this day and age, it is so complicated to know what to eat. But like Michael Pollan says, you should eat food or things that look like food, not too much of it, and mostly plants. And I think that this is a really simple way to think about your food. The more processed our food is, the less it is like food. But I do want to specifically point out the one particular diet that has been consistently shown to lower cardiovascular disease, and this is the Mediterranean diet, which is primarily composed of fruits and vegetables and nuts and some fish and some good oil. And so this is a study it was a randomized control study. They included about 7,500 people, all free of cardiovascular disease at the start. It had over 50% women, and they followed them for about 5 years. And they were randomized to either a Mediterranean diet or control diet. And they found that there was a 30% reduction in cardiovascular events. And so again, huge. Like, these are really powerful strategies for prevention. And so then when physical activity and diet do not get us the numbers that we want, like they don't get our cholesterol where we want it to be, we may need to be thinking about medicine. And so I wanted to start bringing up some medicine. And a lot of people that I see in my clinic are kind of resistant to medicine, but we definitely use a lot of lifestyle to get us where we want, but sometimes there's genetic factors that get on our way, and we can't always control everything. And so I just wanted to point out these are the 2013 cholesterol guidelines. These came out the same year that Calculator did. And there are 4, the way we look at guidelines is there are 4 what we call statin benefit groups. And the first statin benefit group is the first one, clinical ASCVD. That just means anyone who's had a heart attack or a stroke or peripheral artery disease. These people clearly need cholesterol management, and statins have been shown to be very helpful. The next theory groups are broken up into usually by cholesterol. Their cholesterol's a little high. Maybe they have diabetes. And so the next 3 primary prevention categories give us an idea of when we should be talking to a patient about statin therapy. So the first one there is LDL of 190 or above. And that category is really trying to capture people who have very high cholesterol and maybe even a familial component to their cholesterol. The second category are people who have diabetes and cholesterol that's not quite as high as 190, but still elevated. We tend to calculate their risk score, and by their risk score, we determine whether or not we should offer them a statin. And then the next category are adults who don't have diabetes. Again, we calculate their score, and we if the score is high enough, we offer them statin therapy. And in primary prevention, the really big thing is statins have benefits, but they potentially also have risks. And so in primary prevention, we want to really balance the risk and the benefit. We don't want the risk to be higher than the benefit. So I want to talk a little bit about the benefit, because that's where a lot of the controversy has lied. So in primary prevention in women, the controversy has been, is it really that helpful in primary prevention when they have not had a heart attack yet? And I think a lot of the controversy has centered around the fact that we don't have a lot of data in women. A lot of these clinical trials have enrolled women, so we just don't know a lot. But this is a very large meta-analysis that looked at this exact question, which is statin efficacy by sex. So looking at it, males versus females. So included 27 randomized control trials that were statin versus control. It had included 175,000 people, 47,000 of them were women, and there was at least a follow-up of 4.9 years. And what they found in this meta-analysis is that the effect of statin treatment was similar among men and women who were at similar cardiovascular risk. And what they've also found was that for every 1 millimole per liter, also equivalent to 18 milligrams per deciliter, which is the unit that we use in the United States, but for every 18 milligrams per deciliter reduction in LDL, this statin was associated with a 21% reduction in non-fatal and fatal cardiovascular disease. And this was true in both primary and secondary prevention. So I think this particular study does help us better understand that it appears that women do benefit as much as men do, even in primary prevention. And then I want to talk about hypertension, because what's happening in hypertension now has changed a little bit. We have updated guidelines in 2018 that have lowered the cutoff for hypertension. So the cutoff for hypertension, the definition used to be 140 over 90, and now it's been lowered to 130 over 80. So now we have a lot more, millions more people who have hypertension. And the reason why this particular definition was lowered was really to try and capture some of the people who have complications from a blood pressure that's between 130 and 140, and also to try and institute preventive strategies and therapeutic strategies earlier. So one of the most important studies that's come out recently is something, the acronym is SPRINT, and what they did in this particular trial, it was a randomized control trial that randomized people to either intense blood pressure control or standard blood pressure control. And what they found was in the intense group, which is 120 over 80 or less, they had a 25% reduction in cardiovascular events compared to the standard group. So that was one of the main reasons why this blood pressure cutoff got lowered, because they realized that people do tend to benefit from a lower blood pressure if they can tolerate it. And so there's still a little bit of unacceptance perhaps by some providers as to whether or not they're going to adopt this. But currently, the current evidence is that lowering your blood pressure, as long as we don't create too many side effects, it does appear to reduce cardiovascular events. So these are the treatment goals. This is sort of an algorithm, and you don't have to pay attention to the whole thing, but it's really just looking at stage 1 hypertension, where the blood pressure is 130 over 130 to 139 over 80 to 89. And what we tend to do in this particular group is, now this is a new group of hypertension. Before, we used to call them pre-hypertension. And so if someone falls within this category, we will look at their additional risk factors for heart disease and stroke and calculate perhaps their risk score. And if it's high, instituting medicine, and of course, on top of that, making sure that the behavior modification is in place. And then really trying to counsel patients on the meaning of having blood pressure that's elevated and the importance of lowering it. And normal blood pressure is 120 over 80. So in the lower groups, before their blood pressure reaches 130 over 80, we do a lot of counseling to try and lower their blood pressure naturally through diet. It's usually low sodium, exercise, and weight loss. Okay, so I'm going to end on this medicine, aspirin. So aspirin is the other very controversial thing that tends to happen. And I find that a lot of people are less afraid to take aspirin than they are to take a statin. But it turns out, I'm not exactly sure why. I think maybe because aspirin's over the counter and it's more readily sort of available, but aspirin has its risks too. So aspirin, the biggest risk with aspirin is bleeding. And so anytime we think about starting aspirin, we really want to make sure that the risk does not outweigh the benefit. So in women specifically, one of the largest trials that looked at this question of whether or not aspirin is helpful in primary prevention was the Women's Health Study. So this study included 40,000 women older than 45 years old, all free of cardiovascular disease at this beginning. They were randomized to 100 milligrams of aspirin or a placebo. And they followed them for 10 years. And what they found was that this low-dose aspirin did not prevent heart attacks, but it did help prevent stroke. So in women, it appears that aspirin is more beneficial in stroke prevention potentially. Then they did a sub-analysis that looked at aspirin, and it looks like, at least in older women, older than 65, it may be really helpful in preventing heart attacks. So our advice tends to be, in a woman who's older, we're often willing to give them aspirin, but not in younger women unless they have a family history of stroke. The one thing that has come out since this study is a calculator. So we love calculators because you actually plug in all these different things and it spits out a score. So now we have an aspirin calculator that actually takes into account your risk for having dyspepsia on aspirin, whether or not you take other medicine that increase your risk for GI bleeding, like, for example, prednisone or non-steroidal on a chronic basis. It takes into account whether or not you had a history of peptic ulcer disease or other GI bleeding. And so then it actually gives us a calculation for whether or not the benefit, like what is that, how do we weigh the risk and benefit of aspirin? So it's actually very nice way to specifically look at aspirin, especially in primary prevention specifically. Because in secondary prevention, it's what we call a no-brainer. Like if you can take aspirin, aspirin is very helpful in preventing strokes and heart attacks if you already had one. Great. So that is where I'm going to end in terms of the controversial topics. And so in conclusion, I just really wanted to point out that in primary prevention, we rely a lot on risk factor, just looking at risk factors. And so we rely on these risk calculators, but the problem with them is they do tend to underestimate a woman's risk, her lifetime risk. So it's really important to look at non-traditional risk factors. And I think that it's important for women to know what their non-traditional risk factors are, because even with the pregnancy ones, they often, if something happens in pregnancy, that is not necessarily conveyed to the primary care doctor who then takes care of that patient. And lifestyle change is a very powerful preventive strategy for cardiovascular disease. And that on top of that, though, aspirin and statins do play a role. Thank you.